hearts. This is lymphatics and immune. And I normally stay away from the textbook, the Welsh Whole, but I figured I'd look at it to see the degree of detail that was there, and I don't mind starting with it because it seems pretty good detail. It's basically a physiological system.
I literally don't listen.
The anatomical portion are called lymphatics.
His classes.
You probably saw it a little bit in blood vessels. These travel along with veins. Lymphatics are not a closed system, but an open system. They're open in the tissue level, and they pick up particles that are really too big, too heavy, not compatible with going in a capillary, which is so tiny, without clogging it up or damaging it, and eventually carrying its way and joining the general circulation at a big blood vessel, like the superior vena.
You'll be on.
It's interesting. This is where a lot of, unfortunately, diseases travel. Bacteria, viruses, because they're fairly big structures, travel in this area. Things that are heavily laden with, proteinaceous or fatty, travel that way. And unfortunately, bad cells. When we talk about bad cells, we're talking about cancer cells, damaged cells, etc. All of those travel by way of the immune system, and which is the circulatory arm of the immune system. So we have to study what goes on in the lymphatic system because there's not a lot of anatomy, because basically they don't overly name the vessels. It's very specific. What's interesting about them is it's almost a system where they're collecting this material we call lymph. That's where they derive their name, this lymphatic fluid, which we collectively call lymph. And it gets filtered along the way multiple times at little weigh stations that are like giant funnels. And what they do is they sort of have multiple things going in and very limited things going out. So imagine you have multiple inputs and maybe only one or two outputs. It takes a long time before it sort of works its way through all these little nooks and crannies. And that's where your body's immune system is identifying, triggering, starting to produce, depending on what it needs to, either cellular-based immunity or immunity that's based on antibodies. And we're going to start talking about the difference between B cells and T cells, things like that. So it's a very complex, very, very complex system.
Oh, I got extended.
I want you to know that going into
school at least July.
Okay.
So we have a little bit. I don't have a separate handout for the lymphatics, but I do have one. And I put this together ages ago using the brief textbook.
Oh, well, that's
actually, that's the code for CCAC. If you didn't know, for their AP2, what they call Biol 160. I never bothered to change it. So it might even have some figure or key things that I refer to. But look at all the stuff that's in this.
April.
Antigens.
Oh.
See, I have some of these where it says like figure. You just ignore that. It was a different chapter back then, et cetera, et cetera. You can see all the different figures that are there, but you're going to see the same figures anyway. So all of this, there's an extensive, I forget how many pages this is, but it's like a dozen pages. All for you, again, at no extra charge. If you subscribe to our channel at an initial rate of $49.99 and then $20.99 every month.
Let me just do another one. It won't let me do it for some reason. Like it's.
And we'll take you to court if you try to stop.
Or whatever. And it's like.
See, some of you. Some people would have enjoyed that, but I can see you're just off of break. For those of you who are still here, we can only see the people who are not here. I got some legal trouble during break, which surprises me. Yes, I know it wasn't broken.
Whatever I had and my daughter had was absolutely miserable.
Yeah, and what else is new? What else is new?
Sinus infection with the antibiotic.
Just wondering about that, and I didn't get in any trouble. No more than I usually do at any point in time. So that's there for you to look at. So without any further ado, let us begin. So this is chapter 16. It's lymphatics and immunity. There's a lot of material. The next exam involves blood vessels, which you have just completed, and this chapter, lymphatics and immunity. These effectively, it's two chapters.
It was not fun.
There is a lot of complexity to it. Traditionally, anatomy and physiology students in my classes have found this to be the hardest chapter, the hardest exam.
Yeah, I had all these.
You straight up, I put on Blackboard already, if we go over there and look at your Blackboard, which I loaded it to already, you will see I have the immune chapter, which I
a lot of
called
times
it,
like t-shirts.
the handout, and then the marine chapters,
I
which
get
is
the
certainly
break, whatever,
referable
then
from
like-
A, B, and C.
Yeah.
That's when they get sick.
70 chapter 20.
No.
Okay, all those powerful.
Yeah, no, it was.
So
it
you have
was
what to study from this.
whatever.
Lots of resources plus listening to me. What do you want?
I just want to do my
Hold on
freaking.
1 second.
I don't know my login though, because I've never had to do it on here before. I've always done it on my phone. I meant to do it on my way into work or on the way into school
Okay.
when my
Sorry
car
for
was
the way I
driving.
had to answer that one. Okay. And off we go.
That's-
So I'll jump over here to where this is, and we can take a look at it started here. So the lymphatic system.
It was definitely beneficial the other
When I
night.
say a physiological system,
was
it's more about the
Definitely
action of
tired
cells and the
on
action of
Saturday because I
chemicals,
didn't get home
and
until
really
like
the
almost
nature of these
1.
anatomical passageways.
And
The vessels are just really to help
I had to
fluids
work it like
make their way out. And
8
because a
the
lot
next
of what I
morning.
mentioned to you before, a
I
lot
was
of
like,
problematic things, viruses,
I didn't get to sleep till
bacteria,
like
cells that have
2:30.
been damaged,
Yeah.
make travel along this system.
Tired.
That's where it comes into play. And
So
yes, it's
I was
really
like,
just
man,
another
this
part. We were
sucks.
looking at edema at the
And that's
very
what happened
end
to me
2
the
weeks
night
ago.
before.
Sometimes the
We were
edema
gonna
is
go to
caused
brunch
by
on
blockage of the
yesterday,
lymphatics. The most famous of these
and come to find out, like I found out Friday that I
it
wasn't
happens
working
from
3 to 11.
a particular mosquito or fly bite in Africa called
And-
elephantiasis. What it does is it clogs the lymphatic channels, and you get these enormous legs
I don't think you.
that look like an
do.
elephant's legs, because the fluid is so thick and deforms them over time. There's not a whole lot you can do with those, unfortunately. So what does it do? Transports these, when they talk about excess interstitial fluid, that's fluid that's in there that can't fit in the capillaries for whatever reason. And generally they're fatty laden or fatty or heavy proteinaceous. You know, things that have a lot of stuff in them, they're going to, in my way of thinking, clog up capillaries and return it to the bloodstream. Eventually, when do they return it? After it's been processed to a certain extent, and a blood vessel that's large enough to deal with it. Think of the superior vena cava. It's a very, very large vein that's there. So it absorbs lipids from the digestive system. That's part of it. Okay. And we'll get to that. We look at digestive. You have a whole, when we get to digestive, you're going to see that in your intestine, particularly in your small intestine, more than anywhere else, you have these little finger-like projections called villi. Villi means finger, and inside of each one of those finger-like projections is a lymph vessel, because it's absorbing all that stuff. Where we majorly come in contact with it, our gut. That's there, and the name of that fancy lymphatic capillary is very famous. You need to remember it. It's called a lacteal, as you can see. Okay, and it's all about starting to understand the immune system and how we are able to deal with it against disease, and identify whether it's something where we have to fight it or something it's good guys to be there. Thankfully, most of the things we encounter are good guys, not bad guys. Okay, so immune system refers to the fact that many of the cells in this system provide defense against disease, and I always think the term permanent is a little strong. I would even just put long-term immunity. Okay, we're going to start talking about something called immunological memory. That's kind of what, when vaccines work, what we hope they do very, very well, okay, and give you long-term immunity. So as a kid, and I've gone over this in micro with some of the students, and we go over it again. We call them the usual childhood diseases: measles, mumps, German measles, which is rubella. That's why you have gotten an immunization for MMR, measles, mumps, and rubella. Well, my kids had the chicken pox, because even though they had the MMR, they didn't have the chicken pox vaccine when they were at that age to be susceptible, and they all got it. We as kids all got those things. Okay. And so, and the immunity from typically getting a disease like that, which you're going to come to learn, is called active naturally active immunity, meaning being counter to disease rather than artificial, which would be an immunization. We have company. It's okay.
This is crazy. I cannot believe it's all talk. Yay.
So all of that, I was going to say something inappropriate, so I'm not going to do it. Good stop. Permanent to me is the wrong term. Long term might be a better way.
Did you get it out?
Yeah.
And here you can see them.
Got it?
So around every time we just went over capillary beds, embedded with over those capillary beds, but these are closed. Yeah, you're going to tell me the capillaries have little clefts and openings? I'll buy that. But in A, not all of them. And B, they're continuous with one another. This opens, it starts here and works its way back through a series of these, what we call lymph nodes, which your mom called swollen glands. Okay, that's what lymph nodes are. And then all the way back, and as you can see, eventually,
I worked 38 hours last week. 30.58. I would have worked 40, but I left early one day.
Remember, from your heart, we have the right atria, and coming in from the top, superior vena cava, coming from the bottom, inferior vena cava. And it has a very, very specific way, and I'll go over the flow. It's divided asymmetrically, to be the right word for that. So it starts with capillaries, lymph capillaries. This is the anatomy part of the program. The capillaries form vessels. There's no specific names. We just say lymph capillaries, lymph vessels. They flow into the sear, and it's not just one node. They're collection stations. So think about that. You want to think of where do we have a lot of lymph nodes?
Something, and it was literally because I kept doing
get a ton up
motion,
here because most of the time,
and like,
and
I was like,
infections are upper respiratory.
it's something.
So we have them behind the ears, in front of the ears, sore throats, in your neck. Okay. Internally, you have them all throughout the gut. The breast is an area, particularly in women, particularly with nursing, and vis-a-vis breast cancer. So you have a tremendous amount of nodes in the axillary areas rather, and then in the groin, tremendous amount. Those little crooks, elbow, knee, up here, where we have the torso coming together with the extremities. Here, lots and lots of lymph nodes. And what physicians do and nurses do when they're on their game, if you see it, you're seeing an infection in somebody's pinky. It's like you're going to start feeling here and feeling here, because if you've got swelling here, that tells you now you have what we used to call in my day and age blood poisoning, which didn't have anything to do with the blood, but it was traveling through the lymphatics. It was called lymphangitis. And normally you'll see a red line that goes along with it. So these are all little goodies I'm telling you. And whether you're going into a medical field or not, doesn't matter, because whether it's your kid, whether it's you, whether it's your significant other, people get these things all the time. And it's actually, when you see something like that, there's a destination for them. It's called the emergency room. Stop. Do not pass. Stop. Go directly to the emergency room. Do not go to the urgent care. You have that when you have lymphangitis. My opinion. And you're going to see those nodes flow into bigger vessels, makes sense, and specific trunks, and then collecting ducts, and eventually into the subclavian veins, which happen, and the subclavian veins kind of come together with the jugular veins, and they make up the superior vena cava. Without going crazy about the anatomy, and you don't have to remember all that, you're going to see the way they're divided. The right side of your upper portion of your body and the right side of your head goes through something you're going to see shortly called the right lymphatic duct. Everything else goes through something called the thoracic duct. You'll see that shortly. That's there. So the anatomy of it's a little. It isn't the right side is in this side and the left side is in that side. It's a little bit different. That's a little funky. So we'll start with the capillaries. Very tiny. Can't see them. When they say closed-ended tubes, the one end that they're flowing to, you have to think of as closed. The other end, where they're in the capillary bed, is open. They're there almost exclusively with every capillary bed around. They're very thin walled. That's good because big stuff can get in and it'll stretch. Mostly simple squamous. And the fluid, once it gets in there, is lymph. Effectively, it's tissue fluid. And then they eventually come together and form larger vessels, just the way tiny capillaries, little networks of capillaries eventually feed in commonly into venules, and networks of venules become veins. It's no different than any other part of the circulation. Voila. They're not depicting them as open, but they're open. They have little flaps here. And interestingly enough, they have valves like veins. And the valves tend to ensure that they're flowing in the right direction. And the same thing that pumps your blood back, and I've discussed that a little bit before, that pumps your blood back towards your heart, muscular activity. Whether you're inhaling or exhaling, whether you're moving your legs, you're moving your arms, all of those types of things. Every time muscles contract and relax, eventually it's opening the valves. And when they relax, it's almost as the valves close, and suction maybe is the wrong term, but a certain amount of the fluid will come in. They don't depict the valves in this illustration, but I'm hoping they're coming. So they're similar to veins, but thinner. They have the lining layer, maybe some smooth muscle and elastic. The larger they are, they'll have connective tissue. That's anatomy. We're not going to go crazy about that. Valves, one-way flow, that's important. And eventually, you'll see that as they flow into these larger trunks. And a couple of important names coming your way. The lymph has an interesting name. There are going to be two names that when we were studying medicine way back in the Stone Age, 50 years ago. Opportunity to laugh. The stuff that flows through your gut as it's being processed leaving your stomach is called chyme. And the stuff in the lymphatics after it's sucked in there is called chyle. The chyle, digestive stuff, which are digestive, term you're going to become familiar. And when you're really talking about lymphatic fluid, basically it's called chyle. So you'll see that name during your readings, or if you're listening and you hear the term chyle, that's lymphatic fluid. One of the structures where it collects is called the cisterna. Remember, a cisterna is a well. Remember the terminal cisternae with muscles, all that. I know, go back there. T-tubules. You see, now it's ringing a bell. Yeah, I heard about those things before. Okay, so it's called the cisterna chyles. Just thought you'd be interested. All right, what are you doing this week in lab? You doing lymphatics? You did it. Oh, hey, Lou, it's on you now. That's what Dr. Robbins is telling me. You got it. Run with it. So they're showing you. It's nice to see the valve. So the drainage from the lymph from the different regions. So there's no specifics here. I'm not going to ask you to draw a diagram and name this. Nothing like that. But they're all from those areas, and they go into a series of collecting areas. And effectively, here's what's coming. Okay? You have two ducts for two main areas of collection for the entire lymphatic system. The thoracic duct, your chest, obviously, longer and wider of the two, the vast amount of the body. Okay? Like I said, here's the name. That's cisterna chyli, and it empties into the left subclavian vein. So it's pretty much on the left side. You'll see the diagrams, and you'll see, and again, the PowerPoint has effed it up. The right side of the right lymphatic duct, that's why they call it right, does not drain the left upper portion of your body. Beep. This is an error. Strike that. Okay. It empties into it. Bless you. Okay. It is definitely smaller. It drains. That's the term we use. The right half, sort of like the right half of your head and neck, and the right upper extremity only, and goes into the right subclavian vein. Just remember that. Okay. Right lymphatic duct. It gives it away. Right half of the head, right upper extremity. Everything else, thoracic. and they both respectively into the different parts of the subclavian vein, which eventually leads to the superior. Never trust a PowerPoint. So you can see here, I mean, I don't know how well you can visualize that. Maybe I don't think it's the world's greatest graphic, but you can see, look at all the clusters in the inguinal area, the groin here. You can see that this long structure is really the thoracic duct, sort of the continuation of the cisterna chyli. And when you're looking at, when they're talking here, you can see more of the thoracic duct up here. And you can see the right lymphatic duct. This is, I don't know about you, to me, that's the right subclavian vein. I'm just saying. Shh, don't tell anybody it's a secret. Large clusters in the axilla, lots of head and neck areas. You can see we have an abundance of these structures. These are the lymph nodes. Voila. So here you can get some ideas of some of these pathways. That's what I was talking about. The area shaded, half head, right side of head and neck, the right upper thoracic area, and the entire right upper extremity are the area of the all that lymph gets its way back here to the confluence, more or less, of the jugular vein on the right, subclavian vein, and it makes up eventually a portion of the superior vena cava. Good illustration, bad PowerPoint. Here you can see the cisterna chyli leading into the thoracic duct, picking up everywhere. So the entire abdomen, lower extremities, both sides, abdomen, both sides. As you can see here on the left upper extremity, left thoracic, left half of the head and neck, all of that by way of the thoracic duct. And to that left side is sort of confluence of the subclavian vein and the jugular vein. Got it? So here they're just showing you, for example, and that's why the idea of looking at the breast has a large amount of lymphatics. And this is when somebody, when they have a breast examination, whether it's a self-breast examination, mammography, ultrasound, if there's anything at all suspicious and you have to you biopsy something, you always, and I mean always, do a lymph node dissection. Because it spreads quickly, and you'll see when we do breast anatomy, the tail of the mammary gland's tail goes right here into these areas. So it's naturally partly spread. Very significant. So voila, there's the flow chart, which I'm not going to give you a flow chart question. I'll go back and look now and make sure there's no flow chart. We'll have to know about which one's on the right and which one's the right lymphatic duct and which one is the thoracic duct. I'm telling you that now, and then we get into these guys. The fluid that enters the lymph capillaries depends on the fluid. So if it's water and, it's pretty much self-explanatory. If it's tiny particles that dissolve in water, they're going in the blood. They're compatible with the fluid in the capillaries. So it has the same composition, more or less, as plasma, water, dissolved nutrients, gases, hormones. The exception, tissue fluid does not contain large proteins, which are normally staying in the blood plasma for that osmotic pressure, okay? So tissue fluid has certain amounts of plasma without the plasma proteins in general. But again, the heavier, thicker particles, possibly infected or damaged cellular elements, all of those, they're going in the lymph. So, and they're talking about the net formation of filtration from the plasma normally exceeds reabsorption. Okay, so what they're talking about is there tends to be more fluid that creates a push-in kind of a pressure in those spaces that forces the fluid into the lymphatic capillaries. So what's ever left after the fluid's gone to the capillaries, there's enough pressure from it to push it into the lymphatic, okay? And that's designed to prevent edema. So, and this is the classic example, axillary lymph nodes removed during breast cancer surgery, lymphatic drainage is obstructed, and you get upper extremity. And it's very significant, very cosmetically challenging. The word, and we often use a word that you should get used to, it's called stigmatizing. People become very self-conscious of things that are visible to others. that they're not happy with. I mean, it might be as simple as, an outbreak of acne when it's just the worst possible time, or a cold sore can be stigmatizing, anything like that. Unusual body odor can be stigmatizing, but things like that, any type of physical impairment that's obvious and atypical, people look at. And a lot of people get all upset about it, unfortunately, but that's human nature. If you're going into a healthcare field, the other part, sort of companion to that little discussion, is you've got to, you and I might not look at something and feel it's unusual or noteworthy, but people do. People are much more, someone like me is very cognizant about my appearance. Like, I may actually buy a new shirt one day. It's what I already got yelled about that this weekend. Did. You're wearing the same pair of pants. I got complimented because I trimmed my mustache and beard before I showed up. I don't care. But whether you're dealing with the public in a non-medical sense, or just dealing with people in your orbit, or in a medical sense, put yourself in their position. Be understanding, because some people view that as, oh my God. That type of thing. I really mean that. So lymph inside lymphatic vessels, very low pressure. So lots of help. Muscle activity plays a role in it. Breathing plays a role with it. Even smooth muscles play a role with it. The valves are there to fight backflow. And obviously physical exercise helps. So we find the greatest problem with sluggishness in the lymph with people who are either by choice, hopefully not, or by force because they have a condition that doesn't let them be, they have to be sedentary. And then you have to deal with that. That's why a lot of times the referral is for physical therapy at bedside, physical therapy coming at home to try to exercise and do things that will at least limit the severity of the problem. Might be the way I would say it. Okay. So stuff that they pick up. Dietary fats in the small intestine, where most of those lacteals are, getting into the bloodstream after they've been processed. You're going to see they go through a lot of processing. Small proteins filtered by blood capillaries back to the bloodstream. Excessive fluid, bringing it back to the bloodstream. Foreign particles to the lymph nodes. That's one of the first steps on materials for our body to begin to respond to them, if necessary, immunologically. And again, the valves between the cells and allow easy entry of tissue fluid. So there's still, now you're seeing it's a gap like this. You see what I'm referring to? There's little openings here and pressures. It's not a classic opening like a big gap or cleft. It's a mini cleft, but the more the pressure is, the wider it will make that. So that's why even activity helps, because it'll increase the amount of fluid and it'll gradually push the fluid in and create this flow. So you'll have a lot of tributaries, as you can see, moving into it and create this motion. And the nature of the way the anatomy of the flap, so to speak, will facilitate this. You have these tiny little filaments in the connective tissue, so it's not like this. It's not like the end of a garden hose that's flapping around when you got too much fluid going out of it. I happen to like garden hose analogies. We're in spring. We're down in DC for the weekend. They have cherry blossoms. Yes, already starting. They're gorgeous. You like cherry blossoms? Gorgeous. So, some names that you're going to have to get used to. You're going to love this. Don't thank me. Several cell types, including aggregations of lymphocytes, the major white blood cell arm that's part of this by far and away, and macrophages, another big part of it. So those are the white blood cells that really play a role in this system, and collectively we give them the name MALT, mucosal associated lymphatic tissue. You could have it with the skin, the acronym is SALT. With the gut, the acronym is GALT. Okay? So get used to seeing those acronyms. I'm not gonna go crazy with the acronyms, but again, down the road, standardized testing in whatever field you're going to, they're not shy about that. So I mean, if you got something like this that's in all caps staring at you early on in any type of PowerPoint, you got to know what the acronym means. Okay, unencapsulated lymphatic tissue of the digestive, respiratory, urinary, reproductive tracts. Getting the idea that it's everywhere. Tonsils and appendix are composed of lymphatic nodules. What mucosa, moist linings, okay, that are associated with openings into us and out of us. So think what they are: digestive, the whole alimentary canal we're going to look at; respiratory, ending deep inside your lungs, where exchange takes place; urinary and reproductive, and a lot of times the problem is it's getting in because of the opening, the anogenital region, the urethra, the vagina, etc. There's a lot of potential spots. Why do we have an abundance of anything that in contact with what I call the outside world or the outside environment is filled with these isolated areas of lymphatic tissue? That's where the bad stuff's coming from. So our bodies are designed for this. They have a fancy name, these aggregation of lymphatic nodules in the ileum. The ileum with an E, there's 3 parts of your small intestine you're going to have to know for anatomy, I'm sure. It starts with something called the duodenum at the end of the stomach. Some people say duodenum. Either one is right. Then it has jejunum, Jejunum. And lastly, the ileum. Those are the 3 main parts that are very similar anatomically. Bless you. And so the last portion of the small intestine is filled with it, because by this time, what you basically have left in the small intestine is for lack of a better term, junk. Most of the absorption and reabsorption of important things has been carried out. And so these are, when they say unencapsulated, they don't have something around them holding them as a unit. You'll see when you see a diagram of like a tonsil, it'll be it'll look like a bushy thing like this, and in it there'll be little clefts. What happens is the material flowing over will get into these clefts and have areas where it can be reabsorbed or adsorbed in that particular area, brought in. So there's little openings that are there. Taste buds kind of work the same way. So inherently in taste buds, they have sensors that are responding to the chemicals that are dissolved. Here, it will actually pick up stuff. So that's why for years they thought that they're immunological tissue. That's why we don't yank them out. In my day and age, if a kid had 2 sore throats, they were getting their tonsils. They had a tummy ache, they're taking out their appendix. We didn't know enough about immunological tissue. We thought it was the source. It's the alarm clock. The only time and there's nothing wrong with having tonsils taken out when it becomes a source of infection. My eldest and my youngest, my son I just visited, and my daughter, both had their tonsils out, because they became effectively what we call necrotic tonsils. They're filled with infections. They became sources of infection rather than sentinels, guardians for that. So everything has changed. We didn't know, that's immunological tissue. It's there to help you. It's to guard against infections. It's to guard against bad cells. Why would you take it out if you don't have to? You take it out if it's causing damage. So that's part of it. So the encapsulated ones are ones that we either need or it's really desirable to have. I will qualify that. Thymus, we need. The thymus is a gland that without its activity, it provides us with the chemicals that activate the most important arm of our immune system, called T cells. They get their name because they mature and get effectively activated in the thymus. The term activated, I'm using it there's a lot of funky terminology when you do immune system. We go from naive to competent to active. So for our purposes now, the thymus gets them ready to go. Better way to express it, makes them competent. ready to respond to an invader. I'm ready to go. Let me loose. It's like, Grace, it's all that training you're doing. Ready to go. Hey. Versus the spleen, which is nice to have, though we don't have to have it. It's really important, but you can do without it. Because you will learn the liver can take over a lot of its responsibility. Would you rather have it? For sure. Unfortunately, it's one of those organs that gets into trouble. When there's what we call blunt trauma to the abdomen, it's a hollow organ filled with blood, fluid, and tissue. And what happens, it's like bursting a balloon. Imagine, how if you, like some type of object where the walls can rupture and you can alter the fluid. That's kind of what happens. And that can be life-threatening immediately. So lymph nodes, tiny, 2.5 centimeters, about an inch. So they're tiny, located along those tracts, and effectively it's filtration. Okay, all it's doing, it's going through a series. It's like drip coffee. What do we do when the hot water comes in? It drips through all the coffee, and as it's dripping through, it's extracting all the goodies that you and I want to drink. And tea is basically the same way. Okay, so it just kind of makes its way through. It's all about surface area and the materials that are in there, and so they're relatively small, and so it's really and you might, I know this is a long time ago. You had AP1 in the lab. Does the name reticular connective tissue have, is that triggering your memory? You have collagen fibers, strong, thick. You have elastic fibers, stretchy, boink, right? And you have reticular fibers, which are very thin, coated collagen that act like a strainer, a fine mesh strainer. And so what they do is basically lymph nodes are filled with these strainer reticular fibers and a ton of lymphocytes. And what they do is this lymphatic fluid filters through them, and if it recognizes, basically, what the cells do is they're programmed to basically latch on to anything they don't recognize. It's not that they don't have any visual capability. They can't hear something. No sense of smell. It's all about different kinds of markers. You might remember going back to when we discussed cell physiology way back when, that cells have those neat little things we talked about in the blood. They have those proteins we call glycoproteins, little sugars that project. They're like little fingers that are sticking out. So as long as the white blood cell comes in contact with a normal set of fingers that it recognizes for that person, they go, okay, cool, go. But if they get one of those fingers that all of a sudden is like that, why we pick it that way, I don't know, and they latch onto it. Sort of like that. All of a sudden you have a closed fist would recognize, and you have one knuckle that's protruding a very tiny amount. That's enough of a distortion, molecularly speaking, for that white cell. And once the white cell latches on, it starts a cascade of events that we'll comment on and describe in, I always say will. It's like there's more of me. Chicken soupy plurals. I hate it. Don't be one of those. How are we doing today? Don't be one of those nurses. Do we have a bowel movement today? No. And I'm not that interested in hearing if you did. Right. I'm sorry. I'm the patient you don't want. But we will continue describing this. So what's in there? In all of those nodes, we'll start with that. They have white blood cells that attack, and you're going to find when we get into the ins and outs of the immune system, it depends on whether these viruses or bacteria or anything are inside the cell and have altered it or are not. That's a really important point to remember. And there's white blood cells, macrophages, that will gobble them up. And again, we eat things more than anything else to get rid of them. Damaged cells, cellular debris, groups and chains along typical pathways. Again, the neck, underarm. When you talk about supratrochlear region, you're talking about sort of in this area, if you want to think of it along this area. Okay, remember that you had different anatomical structures called like the trochlear surface. Thanks. Inguinal area, pelvic goes along with it, abdominal, thoracic, not in the central nervous system. We have a cell that kind of does this job. Invaders and central nervous system, very bad combination. Usually means significant problems. You might remember there was a glial cell called a microglia. It was a 4 that are in the central nervous system. You had oligodendrocytes, astrocytes, ependymal cells, and you had microglia. Little tiny sweepers that are basically doing cellular debris. And they're just showing it to you. You know, I don't get a lot out of this myself, but here's the lymph node. You can see the size of it. You have lymphatic vessels entering and leaving. And you see schematically, it's a little easier. So this is what I meant. You have multiple inputs. They're only showing 4 inputs here and effectively 1 output, even though 2 and 1 coming out. There's usually a lot more. There's multiple inputs. And what it does is it sort of filters it ways down. So you have stuff pouring in from 5, 6 openings going through, and it's sort of like almost like a checkerboard kind of a pattern. Lots of little nooks and crannies that it works its way through, creating a lot of surface area, and in it goes until finally, and it's worked on. You can see valves are in there, as you can see, to ensure that the flow is going in the right directions. And there's going to be different centers, whether they're B cells or T cells. We'll get to that. And they're there in that same illustration you saw before. Filters potentially harmful particles from the lymph. And it's most of what our immune system is, we don't want to know about it. Surveillance. Most of our immune system, the best thing about our immune system is we don't have it. We're totally unaware of it. Because that means you're fine and it's doing its job. It's one of the things you want to take for granted. The last system you want going crazy is your immune system, because that's the source of what are called autoimmune diseases. When your body starts attacking itself or producing products that attacks itself. Those are things like rheumatoid arthritis, systemic lupus erythematosus, MS. We'll start going. And none of those are diagnoses that anybody wants to have. So, filters potentially harmful particles, immune surveillance, monitors the body fluids via macrophages and lymphocytes that are there. So it's basically, again, sampling the environment along with the red bone marrow. The lymph nodes are centers for lymphocyte production. They're really bored in the bone marrow. The better way to describe it, that's a little simplification. Lymphocytes all start in the bone marrow. What happens if they're activated? And that's when we start getting into some of this confusing terminology. When they're activated, meaning they have been exposed to a bad guy and they're activated, they clone themselves. That's where they reproduce. Except we call it cloning to indicate it distinguishes it from what's going on in the bone marrow. I think would be the way to describe it. And all of a sudden, we've got to make a bunch of antibodies. Let's get busy. Clones itself. We have a really bad infection in a cell. We're going to have to make a whole bunch of T cells. Okay, and as you can see, lymphocytes attack various pathogens depending on, and I'll go into the way we distinguish why one arm and not the other. Macrophages gobble up the debris. And again, this is the idea of disruption of that flow. They could be surgically removed, because you have to remove those things because that's where cancer spread. A great many of them. Breast cancer is the most common. So that's why they look for these things. Cancer cells are found in what they call sentinel lymph nodes, the nodes in the axillary drainage path from the breast to which cancer cells are most likely to spread. And that's what someone who does these examinations is knowledgeable about it, whether doctor, nurse, healthcare practitioner, physician's assistant, nurse practitioner, doesn't matter. They're all going to be aware of that. And they're all going to check on that. Lymphedema from the breast is found in the arm on the side of the body from where the lymph nodes have been removed. And then compression, this is what they use. Exercise, compression sleeve, using gravity, pumping it, There's a lot of people have to pump it out every day and put a sleeve on. And then when they take it's not very comfortable to sleep with that, they take it off, fills right up. Again, maybe I told you, the great actress Kathy Bates had, I think, bilateral. She had it definitely one side. It might have been bilateral. And now she's getting toward the end of her career. But what she did was, 6 days a week. She goes in first thing in the morning, gets it mechanically pumped out. They get the sleeve on. She always wear clothing, that full sleeve length clothing, do her acting roles, and, rinse and repeat. So we will stop there. Thank you. You guys must have had a very difficult break. I am not seeing a lot of activity in this group.